surgery and he is the head of the surgical gastroenterology unit in the University of Cape Town and Groote Hospital in Cape Town, South Africa. Forgive me if I spell it like the name of the hospital. It is a bit difficult. I think it is a Deutsch name. Am I right?
That's right, yeah.
Thank you. Thank you very much. Thank you for joining us. And we are really grateful for that. And also, we know that you promised to continue with those lectures. So we are really grateful for you. You are highly welcome and you can start.
Okay, thank you very much for the invitation. And it's really nice to join you today. It would have been nicer if I could have been in Khartoum, but it's not possible right now.
Yes.
So I'm just going to share with you the screen. Do you see the screen?
Yes, we can see it.
And I'm just going to move my windows around a little bit. So I've got a little question window down here as well. So people are welcome to ask questions at any time. And if they want to pose questions using the, let me just get that up again. I just want to open that question window here before I start. Just one moment. Actually, I don't see the question window now. But maybe if there are questions coming up and maybe you can just keep an eye on them.
Yes, I'll keep eye on the chat. And also I would like to ask Dr. Mohammed Abbas to start the recording.
Okay, right.
Okay. Thank you very much.
Okay, right, so we can start.
Yes.
So the topic you gave me was hepatobiliary trauma, and I have interpreted it literally so that we're only going to talk about liver and biliary. Usually one can add pancreatic trauma in here as well, but then the topic gets a little bit much. So I'm going to concentrate on hepatobiliary trauma only, and then I also have a case in the end that we can just go through with a little bit of a discussion. I think that demonstrates many of the points. Do you hear me well?
Yes, very well.
Right. So I think it's important to, even if we speak about liver trauma or hepatobiliary trauma, to realize that we shouldn't forget the initial management principles. And I think it's pretty standard in the world now that we follow the ATLS principles when we're dealing with trauma patients, going through all the steps. There's another course, a follow-up course to ATLS, specifically for trauma, that is called DSTC, Definitive Surgical Trauma Care, that sort of adds on to that very nicely. In other words, if a patient is still alive after your ATLS maneuvers, what do you do next? And that's a very valuable course. That certainly helped me a lot, and is specifically directed at surgeons and to make quick decisions and right decisions. So there's a couple of things when it comes to liver trauma that one has to consider. The one is damage control surgery. We'll come back to that. It's important if you are in a center where you deal with these patients that you have to have a massive transfusion protocol in place. And then very importantly, you have to have a warm theater. Use body heating devices, use warm fluid, because your enemy really in this situation where you're dealing with big liver trauma patients is if they get hypothermic, if they get coagulopathic, and if they get acidotic. So physiologically, these patients are very unwell, and especially if your clotting mechanism starts failing, you can get yourself into deep trouble. So quick decision making, keeping operating time as short as possible, is really one of the keys to success in these patients. This is just an idea of what our spread of liver trauma patients look like. It has, and obviously that would vary a lot in different centers in the world. And it's also a changing demography in this. So you can see here, 1994 is chosen here. That's the year of the first democratic elections. And before that, what is marked in yellow there are the statistically significant differences between the two time periods. And you can see that up to 1994, blunt trauma was quite prevalent, and stab wounds. And then if you go to the later period, that gunshot wounds became a lot more prevalent. You can see it in the associated organ injuries, that those have increased a lot, and especially 3 or more organs. So importantly, these patients after gunshots of the liver often have associated injuries, almost half of them, or more than half of them actually, and that is also reflected in the mortality that is increased from 5% in the first period as compared to up to 20% now in the latter period. So the problem really when you deal with liver trauma, hepatobiliary trauma, is twofold. Early during the operation, your main enemy is bleeding. You don't really have to care so much about bile leaks and so forth. So it's really all about stopping the bleeding from the liver. And then later on, if the patient would have survived the first treatment, you may run into trouble with later complications, most of them sepsis related. In other words, you've got a free bile leak, biliary peritonitis. There may be some devascularized areas in the liver where you've got necrosis or necrotic tissue that's been infected, and also septic complications due to some other organ injuries. And these also result in 2 mortality peaks. So there's a first peak where the bleeding initially will result in patients not surviving, and then later on, when the septic complications set in, that those are not manageable and that patients succumb due to those. So a couple of key points I'm going to touch on is, first of all, when do we image? When should we do immediate intervention?
I think the slides now.
Okay, sorry, it's all okay? You hear me?
Yes, all is okay.
Okay, good.
So,
first of all, imaging versus intervention. So in other words, do we have time to perform imaging on a patient, or should we go straight to the operating theater? And then also, which patients can be managed non-operatively? More and more patients actually nowadays are managed non-operatively, and that is both for blunt trauma and penetrating trauma. What is the optimal surgical management? And then, as I said, some more discussion on damage control surgery, which is very important in major liver trauma. Just a couple of words on the AST classification that I think is the most commonly used for liver injury. Important to realize that this is not something that can dictate the treatment. As I've already mentioned, it's more the physiology of the patient, and to a degree the extent of the injury that dictates treatment, but it is not followed. It's not directly related to the grade of the injury. And even grade 4, grade 5 injuries are treated sometimes with reasonably conservative measures, at least initially. Just some examples. So here, grade 2 injury. You look at the hematoma and lacerations. There, grade 3 injury. And there you've got a grade 5 injury. This is actually a post-mortem picture of a patient that was shot through the IVC in the top of the liver and took all 3 the hepatic veins. So quite a spread of severity of these injuries that you can encounter. So there's been a treatment evolution over the last 20, maybe in particular 10 years, where certainly when I was a registrar, it was mandatory operation in all of these patients. Nobody would think of doing non-operative management. And then one started to do selective non-operative treatment in some of these patients. And then when that went on to non-operative treatment with selective operative intervention, especially for blunt injuries that a very large portion of these patients are managed, for penetrating injuries as well, that are operated non-operatively. So imaging versus intervention. When can we do imaging? As you can see there, it's a CT scan. That is really the imaging method of choice. for liver trauma. With a new scan, you can get a reasonably good scan in pretty short time with the multi-slice modern scanners. It's good to have a arterial phase and a venous phase that may give you an idea if there's extravasation of blood, which vessels are responsible for that. When can we do it? In a patient that is hemodynamically stable, and if there are no peritoneal signs, or that there's very localized peritoneal size that may be, say, directly related to a stab wound where the patient is sort of localized tendon, or has got localized tendons over the stab wound, but the rest of the abdomen is soft. And then intervention, obviously, if patients are hemodynamically unstable, their place is not in a CT scan. And if they are peritonitic, in other words, there's some suspicion of associated injuries. So I've mentioned CT scan. Unfortunately, in many, maybe especially smaller centers, the CT scan is not close to the trauma center. Big trauma centers where they have got a lot of resources, these CT scans are often just next to the emergency operating theater, or sometimes inside, and you basically just swing the beds around and the patient is in and out in no time. But I think the way that it's used often depends also on the logistics, how easy it is to get a patient to the CT scan. Inappropriate use of CT scans is really something that one should not practice. And in trauma circles, they often talk about the donut of death. If you stick a patient in there that shouldn't be there, these patients can be damaged a lot, and many of them won't survive. So coming to non-operative management, so which patients with an isolated liver injury can we manage conservatively? And there's a number of criteria that we have to fulfill before we consider it. And you divide those into bleeding. So a patient that after initial hemodynamic stabilization stays stable after resuscitation, usually fewer than 4 units of blood transfused to get them up to a reasonable HB, and also no associated injuries. Clinically look at abdominal pain, that there should not be abdominal pain away from the injury site, and also no signs of peritonitis. Imaging in these patients needs to be done, and on the CT look for free or retroperitoneal air, look for localized bowel wall thickening, and also look at the trajectory if it's penetrating trauma to a bullet or a knife. A tract near a hollow viscus with surrounding hematoma should alert you to the possibility that there is an associated bowel injury. There is a caveat. So for blunt liver trauma, many of those can be operated with non-operatively, probably about 80%. But when it comes to penetrating trauma, only about 30% of those patients will be eligible for non-operative management. Just a series here from our hospital on the selective non-operative management of liver gunshot injuries, and it's a code that was looked at from 2004-2008, and you can see there 195 patients with gunshot liver injuries. Just about 2/3 of them went to operation, and a third of them were operated non-operatively. You see it was fairly successful. In 92% of these patients, it was successful. There were some complications that had to be treated. And in the 5 patients that failed the non-operative management, just going to show you what the problem there was. There you have the 5 patients. Can you see my arrow? If I move the arrow, is it visible?
Yes, it is very visible, yes.
So you can see in 3 of these patients that there were associated injuries that that was probably missed initially, and then in others where there are complications due to the liver injury itself that mandated or needed laparotomy in these patients. So when it comes to a trauma laparotomy, and this is basic trauma principles, is when you drape the patient, drape the patient from the sternal notch all the way down to the knees. The reason for that is that you don't know in patients with big trauma if you have to go into the chest, and also if there are vascular injuries, you may want to harvest, say for instance, saphenous vein on the thigh for reconstruction of lesions. But importantly, even if the patient is draped sterile, exposing a lot of the body, not all of that should be exposed during the surgery to prevent the temperature loss. So cover the patient and only expose where you actually work at that point. It's very nice to have good retractors. You can see the bottom picture there. Probably poor students that have to hang on to these retractors. If you've got Thompson retractor or something similar, or Omnitract, it really helps a lot in these patients. When it comes to stopping the bleeding, we often talk about the 4 Ps. So push, Pringle, plug, and pack. And we're just going to look at these ones individually. So when you do your laparotomy and you see a fractured liver like that, the first thing you do is to push. And the principle is very simple. That part of the liver that sort of fracture in the liver with the liver apart, the whole surface will bleed. And what you basically do, and as they show on the right picture, they're putting swabs on the liver surface just to give you a little bit of traction. The first maneuver is always just to push together the surface of the liver and try to restore temporarily the anatomy of the liver. And the fact that the liver surfaces sort of push on one another, if it's venous bleeding and the CVP is normal on the low side, that will usually control to a large extent venous bleeding. And if that stops the bleeding, you've got time to talk to the anesthetist, ask them to catch up, check on the patient's parameters in terms of the pH, the temperature, the lactate, and so forth, and use the time to plan further treatment. Just Pringle maneuver, even though it's the second P, one has to be very careful with Pringle maneuver. I like this picture because that's the way that you should not put a clamp on the hepatoduodenal ligament. To put a clamp blind from the right side of the patient, where there are sharp tips maybe on the clamp that you use. There's a risk of injuring structures, especially the portal vein, or if you go a little bit too deep, the inferior vena cava. And the way I like to do it is where you can see the clamp there, is to put a finger through the foramen epiploicum. Use your left second finger, your show finger, put it through the foramen epiploicum, bring it anteriorly through the minor omentum that is usually very thin. If you're not obese, you can see that finger. Just make a little hole, and then you put the one clamp of the controlling device on your finger like that. Run it behind the hepatoduodenal ligament and close it. And that is the quickest way to get it around in a bleeding patient. Otherwise, if you think you may need it later on, you can also just put a vessel loop around it that will open it nicely for you to apply a clamp. But important to apply the clamp from the left side of the patient. So this is the strategy that we use. Stop the bleeding, restore the blood volume, and often with pushing and resuscitation, about 80% of these patients, the bleeding will be controlled with pretty simple techniques. And at the end of the operation, you just drain the liver and you close or drain the abdomen with drains close to where the trauma occurred, mostly to also, certainly some bleeding to drain that so you don't get infected hematomas, but also to externalize any bile leaks. Sometimes you may need to use a Pringle. Importantly, a Pringle there is a best before time for it. You can't Pringle the liver, it will definitely stop bleeding, but if you leave it on too long, the liver is not going to be viable. So a very good practice is to, when you do a Pringle, tell the anaesthetist to record the time and to remind you after 5 minutes that you still have a Pringle on. And when you take the Pringle off, tell the anaesthetist so that they know that the flow to the liver has been restored. And you can also keep a record of the ischemic time of the liver. So if you've got a bleeder that a bleed where the pushing doesn't do all, quite often that would be an arterial injury, and if the injury is not too extensive and you've got a bit of experience and the patient is reasonably stable, you can look into the crevice, see if you can identify any bleeders there that you can oversew or tie off. CUSA is mentioned here. I think very, very, very limited role in trauma. I'll come back to that later. And then you've got other adjuncts. You can use Liger clips, you can use sutures, you can pack omentum in a crack, although I don't think I've ever used that. If you've got an argon beam coagulation device, that is quite helpful. And hemostatic agents, some of these flow seal or Surgiflow, and some of the membrane type hemostatic plasters may also work. I'll talk a little bit more about the plugging, usually used in patients where there's a bullet or a knife track through the liver. Just an example of sutures that are placed into the liver, and you can see here that they've buttressed the sutures. The liver is quite fragile, and if you pull too hard on sutures, you may tear the liver, and then the problem becomes worse. So you can use some, often rectus sheath, you can make little buttons of those and buttress the sutures so that you do not tear the liver. There you've got an example of a plugging, so a through and through injury in the liver. Stark and Blakemore tubes that you use for controlling bleeding esophageal varices work very well. So you put the esophageal balloon in the liver and you inflate it. And again, very good for venous bleeds, not so good for arterial bleeds. The nice thing here is, obviously, it's put intraoperatively. You take it out through an incision in the abdomen, and you secure it to the skin as you would do with any drain. And then this can be removed without doing a laparotomy. And what is often advisable, if that did control the bleeding and you plan to remove it, is just deflate it first and wait and see if the bleeding recurs. If the bleeding doesn't recur and the patient stays stable, then it would be the time to remove it. So if you've got a Blakemore Starken tube, you use that. You can also make your own sort of plugging device with a piece of Penrose drain and a nasogastric tube, as they show you there, and quite nice if you've got a through and through injury in the liver. But there will be 20% of patients where the bleeding is not controlled, and usually those are large, complex venous injuries of the liver. When you get big bleeds during a trauma that are difficult to control, usually they are venous. Just to come back to the sources of bleeding in the liver, I should have mentioned that a little bit up front. I think I'm just going to go back to that slide because that's a very important point. And that is, remember that the liver has got a dual blood supply. You've got a hepatic artery that supplies about 20% of the parenchymal blood supply, and then you've got the portal vein supplying 75 or 80%. And of those, the hepatic artery is actually quite a small artery. So usually not a very big bleed, but a high pressure bleed. Whereas the portal vein, if you've got a significant portal vein injury, it will be a low pressure, but a high volume bleed. And then the other obvious source of bleeding would be the hepatic veins and the inferior vena cava that is very closely associated with the liver, with the retrohepatic inferior vena cava basically plastered onto the liver and sometimes even surrounded with it by the liver if the caudate lobe goes around the IVC, as you sometimes find. So 3 sources of potential bleeding: the hepatic artery, the portal vein, and the hepatic veins / IVC. I'm just going to go show you an example of a patient with a massive injury. Unfortunately did not survive this. I'm just going to run you through it quickly. I'm just stopping it there so that I can move the cursor. So you can see a patient with a through and through injury right through the top of the liver. You can see massive destruction in the liver with still some blood in the hepatic veins, but not much of a reconstitution of the IVC there. And strangely enough, not much else going on in the liver. And this patient was actually initially treated conservatively, but then became unstable. A laparotomy was done, and it was just one massive bleeding from the inferior vena cava, suprahepatic, and all 3 of the hepatic veins taken down. Packing. I think this is probably your best friend when it comes to significant liver trauma. Question is when to do it, and then importantly also how to do it. So there are 2 kinds of packing. The first one is resuscitative, and the second one therapeutic, and they're a little bit different. So if you look at resuscitative packing, that would be a patient where you open the abdomen, there's a massive liver injury, it is bleeding actively, it's bleeding so much that you basically cannot see anything. And if you don't control that injury very fast, the patient is not going to survive. So what you do at that point is, as I've already shown you, do not try to do anything else but pack that liver. Restore the anatomy of the liver with packs pushing on it. Try to put the fractures in the liver together so that you reduce the area that can bleed. And as soon as that is done, you continue with the rest of your systematic laparotomy, looking for I want to say less important injuries at that stage. So just remember, if the patient is not going to survive a bleeding, there's no reason to, at this stage, go look for bowel injuries and things like that. The second packing we call therapeutic packing, and that is if the first 3 P's failed. So the pushing didn't help. A Pringle may have helped, but it can't be there forever. Remember that the Pringle is also not going to control bleeding from large hepatic vein injuries or an IVC injury, and where the patient was not a case for the plugging with a Senstarken tube or something similar. So what we do then is we do definitive therapeutic packing, and the time to do that, hopefully before the patient becomes coagulopathic or very sour and hypothermic. So it's better to preempt that, but certainly if a patient is coagulopathic, a cold, acidotic, the thing to do is to pack these patients to get out of there as quick as possible and to restore the physiology of the patient, because you're going to have a fight that you're definitely going to lose against a patient that doesn't coagulate at that stage. Sometimes, even if it's less severe injuries, if it is in a center where you think the patient is going to need specialist HPB management or other injuries that may need more experienced trauma surgeons, it's also an indication to pack these patients, even if it could have been sorted out and patient to a larger center. So when is it a damage control situation? In other words, we're going to do an abbreviated laparotomy. We are not going to close 10 holes in the small bowel so that it doesn't leak. The infective complications are secondary in this situation. You try to keep the operation as short as possible. When a patient is hypothermic, temperature under 35, when there's a severe metabolic acidosis, so if the pH is under 7.2, if the lactate is above 5, and if your perception is that the patient is coagulopathic, the patient doesn't clot, and that's usually the case if you had a massive transfusion. And also if you think that the operating time in a coagulopathic patient is going to be more than 60 minutes. This is time for damage control. So what you do, if it's a liver injury, pack that liver, get hemostasis. If there are holes in bowel that you have to control, close them quickly with sutures. If there are segments of small bowel that's severely damaged and maybe devitalized, use staplers just to get rid of it. Don't attempt to do any anastomosis. Patient doesn't need anastomosis in the first 24, 48, and even 72 hours. And get out of there as quick as possible. So the rules of packing: do not put plastic over the liver and then pack on the outside. You almost want the gauze packs to stick to the liver. They sort of provoke coagulation better than a piece of plastic over the liver, so you use them right on the liver. Some people say you should have the packs folded. I like them unfolded because I like to mold them according to the shape of the liver. And it's all about restoring the shape and the anatomical contour of the liver by reapproximating the edges of the defect. Don't stick too many packs in above the liver, between the liver and the diaphragm, for two reasons. The first is that you pack the diaphragm up, and that may restrict the diaphragm, and it could be difficult to ventilate these patients. The second is if you create a space between the liver and the diaphragm, you tilt the liver down, and you will worsen the outflow out of the liver through the hepatic veins. That will give you stasis, and it will increase your bleeding. And also, you may, with tilting the liver, press on the retrohepatic IVC, and that the inflow to the heart is compromised. The preload goes down, and these patients become hypotensive. Do not pack any packs into the fractures. So if there's a fracture, you have to approximate the liver. You want liver against liver, not with a pack between the two surfaces of the liver. Pushing packs into these things can also quite easily tear fragile hepatic veins or fragile portal vein. Use sufficient packs, but not too many. We often talk about a 6-pack. 6 packs, 6 large abdominal swabs should be enough. And I've already said, do not use excessive packing. It may cause cable compression and difficulties to ventilate the patient. And while there are packs in place, we usually give these patients antibiotics. How long should the packs be left in? The evidence on that is quite thin. There's certainly never been a randomization, or not to my knowledge, where you leave in them longer or shorter. Usually when the patient, the physiology has normalized, one can start considering taking these packs out, but don't do it too early. This is a study from our unit, retrospective obviously, but you can see there of the 3 patients where the packs were left in 72 hours, that none of them had rebled. If you look at the 24 patients where it was done within 24 hours, or sorry, within 24 hours, that 8 of those rebled, quite a few, and even at 48 hours, 5 patients of 44. So we would not remove packs before 48 hours, and you can even wait to 72 hours, unless there are other injuries that would necessitate earlier intervention on these patients. But especially in the absence of associated injuries that would need surgical management, you can leave these packs in for up to 72 hours. So if the bleeding continues despite adequate packing. The cause is usually arterial. In other words, and remember that the pressure in the arteries, as I said, is high, usually quite low volume bleeds, especially if it's intrahepatic and if it's peripheral. But these things usually keep on bleeding. And if there's evidence of continuous bleeding, the way that we manage those is not to go look and go fish after the bleeding in the liver. If you've got access to good interventional radiologists, the way to do it is transarterial therapy with coiling of these bleeds. This is how the patients are treated in our unit. Again, an article that is quite old, but still, I think, pretty much how it is happening. Most of the patients are treated with only draining. In other words, very simple procedures. Stop the bleeding. Once the bleeding was stopped, you just put the drain and you get out. As I said, the drain is there to collect any maybe slow ongoing bleeding, to prevent hematomas and blood collections that invariably get infected, and also to pick up any bile leaks. Perihepatic packing, you can see 17% of the patient there, suture 12%. So again, about the large majority of patients, pretty simple treatment measures that control the bleeds. When it comes to resection, there's really almost no place for resection in the acute situation, unless there's, for instance, a part of the liver, often the left liver or segment 2 and 3. So the piece of the liver to the left of the falciform ligament that is completely avulsed. It's sort of torn off the liver, and with 2 surgical clamps that you put on whatever remains of any pedicle, you can cut it out and tie them off. So in the acute setting, very, very seldom that resections are performed. And if they are performed or needed, it's probably a good idea to get somebody that is used to performing liver resections electively as well. Secondly, later at a second look laparotomy, you may see what you see here on the top right picture. There are big parts of the liver that is necrotic. And if there's extensive necrosis, and it's usually not formal resections, it's basically a debridement of the dead parts of the liver. Again, if there's somebody around that's used to working with the liver, used to resection, it's not a bad idea to have that patient, that person involved in the management of the patient. So atrial caval shunt, that is something that you quite often see in textbooks. I'm not going to dwell on this. It's quite heroic if people do experiments or do these training in animal labs, often using pigs. They like to show it on these animals, and that usually sort of kills the pig. And they say that there are more reports than survivors of this method. Just briefly about gallbladder injury. So what do you do if the gallbladder is injured? It's very simple. You take it out. There's no place for suturing a gallbladder to try to close a hole in the gallbladder. If a gallbladder is injured, you take it out as you would do a normal cholecystectomy, and there's not much to it. If there's a patient with extrahepatic bile duct injuries, again, it's usually in the setting of multiple associated injuries. The principles of bile duct repair apply, and again, probably good to get somebody in to help with a repair of the bile duct injury, because it's a little bit similar to bile duct injuries after cholecystectomies, with the difference being that it's often in the setting of multiple other injuries. And again, as I've mentioned, repairing bile ducts should not come first. First is stopping the bleeding, and often these repairs are done at subsequent laparotomies if it's a severely injured patient. So just to finish, or maybe I can just hear, are there any questions up to now from the colleagues?
If anybody would like to ask, just proceed. Unmute yourself and just ask. Nothing in the chat room. Nobody is asking. It seems that it had been very obvious. Yes.
Sorry. Assalamu alaikum.
Hi.
Walid Al-Haj. Just thank you, Professor Edward, for this nice elaborative presentation, and we'll say hello to Dr. Reem. My comment is that the packing, you have mentioned all the precautions that we should consider for packing, like avoiding caval compression and splinting of the diaphragm. But for my colleagues, we have to follow the contour of the liver. We have to back it all. And if there is diaphragmatic injury, it's most probably this is an arterial bleeding. So we have to clean the liver and diaphragm, because we have seen cases with diaphragmatic injuries associated with liver. We used to back it several times because we used like 6 or 8 backs and the bleeding didn't stop. So we reopened the case. So that's what I want to add. The other thing, the delayed use, the use of laparoscopy in patients with sealed injuries. We have a couple of cases where we use a laparoscopy to later, after 2 or 3 days, where we evacuate the hemiperitoneum. We did a thorough wash of the peritoneum without doing a laparotomy and avoiding scars and incisions. And we have seen one case with arterial delayed presentation, which is an arteriopulmonary fistula, where she is a young child. She presents with hematemesis, melena, and slighting of jaundice. CT showed segment 4 aneurysm, and we did selective ligation of segment 4 arteries. So the liver injuries and trauma might present late with these certain complications like aneurysm and arteriopulmonary fistula. And my question is that here in Sudan, we don't have like these nice retractors all over. What about the liver mobilization for the registrars and for the, do you recommend liver mobilization so they can do easy suturing over segment 8, segment 7? And is it routine to do liver mobilization? And thank you again.
Okay. So just the first comment that you had on the diaphragm, as I understood it. So if you've got an associated diaphragmatic injury that you sometimes will find with blunt trauma as well, sort of almost a blowout, to suture a diaphragm together is very quick. I mean, and it's actually quite forgiving as well. So you take a Fe bond. I like to use Fe bond because it knots lightly. You close that, because if there's a substantial diaphragmatic injury and a big venous bleed in that vicinity, that patient is going to bleed into the thorax, and your packing is not going to be effective. The second question that you had about laparoscopy is I think laparoscopy has got a place in trauma. It's still a little bit experimental, and there are some real enthusiasts that do that. They will even try to manage some of these injuries laparoscopically. I think in our practice, severely injured patients, usually the trauma is so extensive and so multi-organ that there's not much sense in this, but it may have a place. When it comes to the fistula, I'm going to show you a case shortly. I think that demonstrates that very nice. And then I think the most important question you asked is the one about mobilization of the liver. One should be extremely careful to mobilize the liver in trauma. I almost want to say you should never mobilize the liver in trauma. If you've got a big venous injury, and particularly on the right, where a big hepatic vein injury, even an inferior vena cava injury, that is contained behind the liver. The moment you mobilize that liver and you mobilize the coronary or and the triangular ligaments, you can get an absolutely massive bleed that is the last of this patient. So I would certainly not advise people to mobilize the liver to be able to suture it a little bit better. In that case, and remember, often you don't know what there is sort of hiding in the deep there. And if you convert a partially contained big venous injury, whether it's hepatic vein or inferior vena cava, to an open one, you create a very, very big problem. So I would, in that case, I would, especially in an unstable patient, opt for packing. As I said, the higher up the injury is in the liver, the closer it is to the veins that really bleed big, but also to the veins that where packing is a very good option. And it's the furthest away from arterial bleeds. If you get an arterial bleed from an injury high up in the liver, it's a small branch. That is usually not a problem initially, at least to manage. So my advice would be is one should be very careful with mobilizing the liver, and if you think the right thing probably to do at that stage is to pack the liver. Right, any other questions so far?
Thank you, Professor, actually, for the presentation. I have two questions. The first question is about the suturing the liver, the way of the purchasing the suture, and what the type of the suture that you are usually using. The second question is about the exploratory hepatotomy. Do you advise it, sir, or it's much better actually to back it and leave it for second day, third day, or after 72 hours backing, and then just see it back? Thank you, sir.
Yeah, so the first question that you had on, sorry, I must just think what it was now. The first one you had was, sorry, again?
About the way of suturing the injury.
Yeah. So a monofilament.
And the way of better finger.
Yeah. So usually a monofilament suture, in other words, not a braided suture, because you want it to glide nicely, and usually something like PDS PDS that will disappear, and I remember when I was a registrar, there was a blunt needle that was used, and the idea of that was that you shouldn't it should part any ducts and vessels and slide around it. I don't think that is still around. That was quite a nice needle to use. It was a hand needle, and a bit difficult to puncture the capsule of the liver, but otherwise it glided quite nicely. Usually a nice big needle, and PDS is what I would use. And as I said, you can use pledgets to buttress it a little bit, and it's readily available. You just cut a little piece of the rectus sheath, and you use that because it does make it tear a little bit less. When it comes to hepatotomy, again, you have to be careful. If you press the liver together and there's still bleeding coming and it looks like bright red blood, it's usually an artery, and we know that compressing the liver doesn't work very well for an artery. And if it's peripheral and it's away from big veins, I think it's reasonable to try and look inside the crevice. But again, there is a risk that if you are close to central large veins, that you get yourself into trouble. It's really up to the individual surgeon assessment and what they feel comfortable to do. And clearly, if you've got a patient that's completely stable, there's not associated injuries, and you've got a tract quite peripheral in the liver, and there's arterial bleeding coming from that, and you can safely open it, and you are routine in working with the liver, it's not an unreasonable, unreasonable thing to do, but it's all in assessment and doing the appropriate thing. It's very difficult to say when you shouldn't and should not, but I think in a stable patient, peripheral injury, it seems to be an arterial injury, and you don't have to do a major sort of exposure of the liver. It's reasonable to go look inside. Just remember that even the plugs that we put, they don't work that well in patients with an arterial injury. Any more questions? Okay, I think otherwise we can continue with this case. And there's a couple of questions in the case, and it will be nice if people volunteer and answer. Makes it a little bit more interesting. So here you've got a patient that comes to hospital with a gunshot wound of the abdomen. The in wound is in the left hypochondrium, so just under the rib cage on the left, and there's no out wound, so the bullet is lodged somewhere. The patient's respiratory rate is 24, pulse is 100 per minute. Blood pressure is, the systolic pressure is somewhere around 90, 80 or 90, and it's received 500 mils of crystalloid and oxygen. Just get it, yeah. Sorry, and the next one is patient is talking, equal breathing sounds, well saturated on room air, pulse 110 minutes is when you assess the patient, blood pressure now 80/60, good Glasgow scale, and the patient is not cold. Any suggestions what we should do for this patient? So we're really at the question where we have to decide whether this patient goes to the OR or whether we've got time to image this patient. I think there's a voting thing here as well, but I don't have access to it. But anybody wants to offer an opinion? There are no wrong and right. There are just some that are better.
Is anybody who's going to answer? Just unmute yourself and proceed. I think now he's starting with the simple things. Yeah,
so I think that an important thing here is to look at the blood pressure. This patient has got a blood pressure of 80/60. There's probably some significant bleeding going on. So I'll just cut it a little bit short. This patient went for a laparotomy. They found a gastric injury that was repaired. There was a diaphragmatic injury repaired. And there was quite an extensive injury of the liver, particularly the left liver, that was packed. The patient was taken back to theatre 24 hours later. The packs were removed and the closed suction drain was placed sub-hepatic on the left side. And it was clearly mostly a left-sided liver injury. So the post-operative course was reasonable. There was some serosanguinous fluid in the drain. There was a fluctuating temperature. And then on day 6, they did a CT scan, and this was to exclude any collection. The patient was doing reasonably well. And I'm just going to run this the CT for you, and you can have a look at it. I'm just going to take you slowly through it. So the chest's fine, a little bit of fluid on the left side. And then you can see where the left liver is supposed to be, that there's a big part of that liver that doesn't perfuse. You look at the vascularity, you can see the right-sided portal vein, but the left-sided portal vein seems to be non-existent. So there's probably an injury of the left portal vein. Get a little bit of an artery up there. So the left artery is probably intact, but there's a portal vein injury. And you can see the bullet lodged at the end of the tract the tract went right through the liver, took the left portal vein, and it's lodged under the skin on the right. Okay, the next problem was that there was a pigtail was placed in part of that collection at the left. He drained about 200 mils, and then the patient started climbing in bilirubin. So from the total bilirubin from 13 to 38 over 3 days. So anybody with any suggestion what we should do now? So the patient is actually quite fine, but there's a climb in the bilirubin, and as I told you, what drains in the drain. Any suggestions? Okay, otherwise I will just continue and tell you what we did. So at this stage, we did perform an ERCP because it was quite clear now that there was a bile leak, and you can see here, there is the pigtail that was placed there where bile now drains. And you can see the distal common bile duct that is reasonably normal, and then you get complete extravasation of the contrast there. Quite a low insertion of the cystic duct and the filling of the gallbladder as well. You can see here that we tried to find some continuity, but the guide wire just went into the subhepatic cavity. At that stage, an MRCP was
MRCP.
Yeah, and you can see here the tract as it went through the liver. Again, you see the gallbladder there, and you can see a little bit of the common bile duct there as well. And I'll just cut this short for you. So when they then went on to place a PTC, so our intention was to try to see how big the defect was, if we could do any endoscopic management of this patient. Very sort of small non-dilated bile ducts, but we've got a very good radiologist that actually managed to put to get a needle into one of those. And as they did the Galangiogram, this is what they saw. So you see filling of the biliary tree, but just look at this area here. Anybody wants to volunteer? Let me play it again. You see the Galangiogram, and then what is happening here?
Actually, there is transection.
Yeah.
The common hepatic duct.
Yeah, and if you look carefully, I'm going to just stop it and take it very slowly. Let's do it there. Just look there. You see that blush there? So this patient
Extravasation.
Yeah, into the portal vein. So there's a big portal vein injury that is not bleeding. And the reason why this patient's bilirubin is going up is because his biliary drainage at this stage is into the blood. So a biliary portal vein fistula. All right. So what we did for this patient, it's something that we call sort of an extrahepatic rendezvous method, is that we went back, we passed a ERCP catheter, again, just to pacify the distal part of the common bile duct. We did a PTC to see where the fracture was in the bile duct. You can see there's actually quite a lot of substance lost there. And then what we then did was to from the bottom to deploy an ERCP basket in this big cavity, and then fiddled with a guide wire from the top until it entangled in the basket, and then pulled it through. And you can already here see that there's a guide wire that has been pulled through into the instrument. And then we performed placed a fully covered stent from the proximal part of the bile duct, bridging the defect that is about that length there and into the common bile duct. And you can notice here that there's no left bile duct present here. Basically, the left liver has become probably completely necrotic, and the bile drainage from the left liver is not significant. Went very well with the patient. He started eating, and then on the 20th day, he went into shock, and again, blood started draining from the drain in the abdomen. And I'm just going to show you what the problem then was. This is an arteriogram And you can see here extravasation of contrast. It's a very quick sequence, but extravasation of contrast from the common hepatic artery. So this patient developed a false aneurysm that bled and bled into the cavity that was still drained by this pigtail that you see there. The patient eventually did very well, didn't need another laparotomy. So just a demonstration of how you can manage some of these complex injuries in terms of when it comes to portabiliary fistula. Usually if you contain, if you block the bile duct there, it's a low pressure leak in terms of the blood that it will stop. And if it's an arterial bleed, as in this case where the hepatic artery was stented to cross that little false aneurysm. So just to conclude, when it comes to liver trauma, less is best. And usually the right procedure is the one that is the simplest and that stops the bleeding. All right, thank you very much. Are there any more questions or comments?
Yes, maybe I will start. Thank you for this lecture, and I think it is very elegant as usual. I have a question in the last case, actually. And then you put a stent in the bile duct and also stent in the artery, yes? Common hepatic artery.
Yeah, no, so in sequence, maybe I was a bit unclear. So firstly, there was the portobiliary fistula or biliary portal fistula that we treated with a covered stent in the bile duct. And that sorted out that fistula. And then the second bleed came 20 days later. And 20 days later, so it was probably an injury on the artery that was not complete, or that there was a branch of the artery that had undergone sort of a clot and was in spasm, maybe the left artery, and a very late arterial bleed. And that was treated by doing an angiogram and putting a covered, a vascular uncovered stent past the leak. That sorted that out. So we know that most of these stents eventually block, but it's a slow process. And during that time, there is blood recruited with collaterals, and also that you boost the backflow through the sinusoids from the portal vein into the arterial circulation. So even if that stent blocks, usually there will be some arterial circulation with collaterals, also with backflow from the sinusoids. So just remember, when it comes to the blood supply of the liver, that the parenchyma has got the shared supply, 20% artery, 80% portal vein. But when it comes to the bile ducts, it's only arterial supply.
Yes.
And if you don't get this collateralization, what these patients usually get is they get a ischemic scleral lymphitis eventually. But if it's a slow process, so that if you can stent it, and it will be a slow process of an eventual block, whereas if you embolize it, it's a very abrupt end to the arterial circulation that the parenchyma will probably be okay with, but not the bile ducts.
So you are buying time for the bile ducts, actually. Okay, and then I guess this was very informative. To be honest, liver injuries are really fearful injuries. And now I think all the residents would have got the idea that if in salvageable patients, I mean that 80% of the patients will get some control by simple process. That is pushing and Pringles maneuver and packing and that. And there is always a window to better prepare the patient. So you can use these maneuvers to make the patient more stable, or to call for help from a senior colleague or a specialist. And one more thing that you say, and I like it very much, it is that you don't do more harm than good. And then bleeding is a priority after all. If in any patient is not a priority to do bowel repair while the patient is bleeding, or to control fecal contamination while there is bleeding. The bleeding is a priority in any patient. So now the floor is open for questions. Whoever would like to ask, just unmute yourself and ask, or you can send it in the chat.
I see there are some questions in the chat. There's one in Arabic I can't read.
No, actually, no question. They were saying that they cannot hear it, and then I asked them to just check their devices and that. Yeah. No question so far in the chat room, surely.
Then, if I may go, thank you, Prof, for the lecture. It will be some kind of cheating for me to ask you about that, but I'm sure one of the good things that you showed in your lecture that the era of endoscopic treatment of a delayed liver injuries, which is, I think, is one of the major shifts. Instead of reoperating with all the risk in there, what you showed, the extraluminal, what you call it in your article, mind the gap. I think it's one of the good techniques, but I also remember a couple of patients we saw you doing the scope for them, where you used the biliary stent as a tamponade for a biliary arteriobiliary fistula. Can you just elaborate more, Prof, if you don't mind? Thank you very much.
Yeah. So I mean, if you get a fistula from an artery to the bile duct, there's basically a bile duct injury, and a stent in the bile duct is a covered stent in the bile duct will sort out the fistula. The bile duct will be covered for, especially if it's a small bile duct, where it covers it very nicely. One of the main reasons to put a stent in those patients, because in these patients you've got hemobilia. So if you've got a portal vein, it's a very low pressure system. So you saw that in the portal vein that was the bile flowing into the portal vein, not the blood flowing into the biliary system, because it's a very low pressure. If it's an arterial injury, it's a high pressure, or an arterial fistula to the bile, it's a high pressure fistula. So you get hemobilia. The whole biliary tree is filled up with blood. And that makes the patients very sick. It's basically, completely block up the biliary system. The bile flow is compromised. There are bacteria, and then these patients can become very cholangitic. So it is not the treatment of the bleeding. The treatment of an arterial bleed is this thing has to be surgically ligated if you don't have angiography, or it should be stented, and that is, I think, what is preferable for the reasons that I've explained, or you have to coil it. I'm talking about bigger injuries further down now. The reason why I would put the stent is more for the hemobilia. So once you've sorted the artery out, that clot can stabilize, and it can be there for a very long time, is to flush out the bile ducts with ERCP as much as possible, and then to facilitate drainage of whatever clots may be left, is to put a fully covered stent to keep the papilla wide open. So that is the main, I think the main use of a stent in that situation, is not to stop the bleeding, because the bleeding won't stop. You will maybe just block it from coming into the bile duct, but you will get a massive hematoma there. And the treatment of the bleeding is angiography. And again, if it's very peripheral, you can block. If it's more central, it's better to stent. And as I said, that the ERCP, and especially a nicely wide uncovered stent, is to keep the papilla open to facilitate the drainage of the hemobilia.
Thank you so much, Prof.
All right. So, Rim, any other comments there or questions?
Actually, Mr. Solomon from Nigeria is asking for the presentation. We will place it in, you can find it in our group. It is the Sudanese Surgical Club. It is a Facebook group. It will be placed there like 2 days later, inshallah.
Okay.
So we are going to thank you very much, Professor Jonas, for this informative lecture. And we we are waiting for more and more from your side. Thank you very much.
Okay, it was a pleasure. Have a good Friday and a nice weekend.
Thank you very much. You too. Thank you very much.